Hello, friends, and thank you, ISRT, for giving me an opportunity to talk on this platform. Myself, Jayesh, radiographer, Government Dental College, Thrissur. Today, I am talking about a review on dental imaging technique. So, the dental radiography divided into intraoral radiography and extraoral radiography. So, intraoral radiography includes biting radiograph, occlusal radiograph, periapical radiograph. Extraoral radiograph includes OPG, lateral surf, PA surf, that is for PA mandible. So the technique used in intraoral radiograph are paralleling film or paralleling technique, bisecting angle technique, slope technique. Slope technique is otherwise known as shift technique. So what is paralleling technique? Here the film is placed parallel to the mouth to the long axis of the tooth, and the X-ray central beam of the X-ray beam is directed perpendicular to the film and the long axis of the tooth. And film holder must be used to keep the film parallel to the tooth. So the advantages of paralleling technique are: one is accuracy. Image produced has dimensional accuracy and free of distortion. And simplicity, simple and easy to learn and use. Duplication, easy to standardize and can be accurately repeated. So the disadvantages of paralleling technique are film placement, which requires a holder to place film, which is difficult to place in children, small mouth patients, etc. And anatomy sometimes make the technique impossible. Example, shallow palate, third molar region, etc. A discomfort, positioning of the film packet can be uncomfortable in many cases. So these are the different types of film holding devices. This is called RIN XCP film holder. This is Have Neos film holder, and this is the bite blocks. So this is Have Neos I mentioned, and this is the basic concept construction of a film holding device. This is the film receptor or the image receptor, holder, where the film or the image receptor are kept. And this area is called the bite block, where the patient is biting the film. And there is a metal ring attached, and the distant end of this attached by a locator ring, where we are keeping the cone of the X-ray beam directed to the locator ring. So the bisecting angle technique is also known as short cone technique. And here the film is close to the tooth, and angle found between the tooth and film is bisect. Tube directed right angles to the bisecting line. Let me explain it. So this is the tooth, and this is the long axis of the tooth or the central axis of the tooth, and this is the film. So this long axis of the tooth and the film makes an angle. If an imaginary bisector bisects the angle formed here and here are equal. That is, an imaginary bisector bisects an angle, the adjacent angles will be equal according to the geometry. And we are directing the central ray perpendicular to the imaginary bisector. So suppose we are considering this film and the imaginary bisector as one triangle, and the imaginary bisector and the central axis of the tooth as another triangle. So when we are directing the central ray perpendicular to the imaginary bisector, the angle formed here and here on both triangles will be 90 degree. And this imaginary bisector is common to both triangles. So according to the theory of geometrical theory of isometry, two angle and one side is equal in a triangle. Naturally, the other side is also equal. That means the length of the film is equal to the length of the central axis. In other words, the same size of the object is getting as the image. That is, the image we are getting is neither shortened nor distorted. So in order to make the central ray perpendicular to the imaginary bisector, we may have to angulate the tube head in different directions in case of maxillary and mandibular tooth. Well, suppose when we are considering the maxillary tooth, we are directing the tube directed towards foot. That is our general radiography. It is coded tilt. And for incisors, we are giving a tilt of plus 40 degree to 45 degree or up to 50 degree as the case may be. And for the canine, we are giving an angulation of plus 45. The premolar, we are giving an angulation of plus 30. And molar, we are giving an angulation of plus 20. And in the case of mandibular tooth, we are giving an angulation for incisors minus 15. So the minus angulation is considered as cephalad tilt. We are directing towards head. That is, in dental radiography, it is considered as minus angulation. So for the canine, we are giving an angulation of minus 20. Premolar, we are giving an angulation of minus 10. And the molar, we are giving an angulation of minus 5. So the advantages of this technique can be used without a film holder. So much comfortable for the patient, and the patient positioning etc. requires less time, and we may no need to use any film holder, so that the film holder need not be sterilized etc. So these are the advantages exactly. So the disadvantage is again the film holder to place the film difficult for the patient in children and small mouth. When we are using white blocks, it will be difficult. And anatomy sometimes make the technique impossible, same as that of other one. The some patient may have gag reflex, that is pushing the film packet can be uncomfortable. And the slope technique is otherwise called shift technique. This is actually same side lingual, opposite side buccal. So the indication are overlapping canine, example mesial root of mandibular molar, etc. And retained roots, unerupted tooth, foreign bodies, etc. So the principle you can see, suppose we are taking a molar tooth where the root canal restoration done, we are, suppose we are taking an ordinary angulation in bisecting technique, we could be able to see only two root assets. So actually the molar in this region, we have given restoration to the four roots of the tooth, molar root. So we are giving an angulation, giving a shift, tube shift is done so that we could be able to visualize the four canals separately. That is the advantage of this slope technique. And suppose there any foreign body like that is placed, whether it is buccally or lingually, we could be able to use the same principle to locate it. And in the case of unerupted canine, whether it is buccally placed or lingually placed, can be well seen. Then the third one is called the occlusal radiograph. So the indication of occlusal radiograph, detecting the presence of unerupted teeth, supernumeraries, and odontomes, and determining the buccolingual relation of the objects, and evaluation of the size and extent of lesions such as cysts and tumors, and assessment of fracture of the jaws can be well seen in this type of occlusal views. So these are called the mandibular occlusal. It can be either true occlusal or anterior occlusal. Here we have taken a true occlusal to get the floor of the mouth of the floor of the mouth. So usually this is indicated if there is any salivary tube cyst, salivary calculate. So this can be seen if it is evident in the floor of the mouth. So this is in the case of a mandibular occlusal, maxillary occlusal, where we could be able to see the whole of the palate in relation to the tooth. So that can be evaluated in the case of cyst and extension of the cyst, etc. So this is the case of true occlusal. So we need a dedicated X-ray film for the occlusal, and we are directing the patient coded or cephalad in the case of maxillary and mandibular. So the last one is called the bite wing or interproximal technique. So the indication of interproximal caries can be well visualized. You can see the interproximal caries and the secondary caries, and the periodontal condition can be visualized. If there is any calculus in the periodontal place can be seen, and whether you could be able to see whether the tooth is deciduous or permanent. So this is a routine regular dental checkup. It is very much indicated, and to see the proximal caries, monitoring the progression of the caries. So these are for the regular checkup. And if there is the restoration is overhang in due course, and diagnosis of periodontal diseases. So this is the way which we are keeping the occlusal, biting film. So there's a biting tab is there incorporated with the film. So this is kept inside the mouth, and we are directing the central ray perpendicular to the biting film. Then the digital ray imaging, it is same as digital radiograph in the like, routine radiographic, and, and dental radiography is also now almost getting replaced by the digital imaging. So the introduction of, since the discovery of X-rays in 1895, film has been the primary medium of capturing, displaying, and storing the radiographic images. And it is a technology that dental practitioners are almost familiar and comfortable with in terms of the technique and interpretation. So digital radiography is the latest advance in dental imaging, and it is slowly being adopted by the dental profession. So digital image incorporates computer technology in the capture, display, enhancement, and storage of direct radiographic images. Digital imaging offers some distinct advantage over film, but like any emerging technology, it poses new and different challenges for the practitioners to overcome. So radiography can be analog in dental imaging and digital. In the digital, we may use the digital scanner, digitalizer, and computer radiography or direct digital radiography. So digital imaging or digitalization, the digital imaging is a modality or the method of imaging that creates an image that can be viewed and stored in computer. This is one. So the equipment needed are an X-ray machine, digital image receptor, sensor, and analog to digital converter, computer and monitor with appropriate hardware, software, and network connections. And if needed, printer can be used. So digital image receptor can be either solid state technology like CCD, CMOS, or flat panel. So the advantages of this technique are no chemical processing is required, image processing of acquired images is available, image can be transferred too easily, and image can be easily and inexpensively stored and retrieved, and computer-aided diagnosis is also possible. So dose reduction of up to 90% compared to e-speed films and have been reported by many authors in diagnosis of caries. And although some researchers do claim dose reduction compared with conventional extraoral films, in practice, the background noise rises unacceptable level. It is now accepted that there is no appreciable reduction compared to the film used in conjunction with RF intensifying screens. Image manipulation is perhaps the greatest advantage of digital imaging over conventional film. It involves selecting the information greatest diagnostic value and suppressing the rest. And manufacturers provide software programs with many different processing tools, and however, some are more useful than others. Disadvantages are receptor must be erased before reuse, and high initial cost of the equipment, and spatial resolution of the film exceeds. And some of the image processing routines are time and intensive, and phosphor plates must be packed in a sterile envelope, and possibility of transfer of contaminated material to patient mouths if the integrity of plates protective envelope is jeopardized. So the extraoral imaging, mainly the panoramic radiograph. So the panoramic radiograph, by virtue of definition of Webster's medical dictionary, the process of generating a two-dimensional image of slice or section through three-dimensional object. And X-ray technique for taking radiographs of layer of tissue in depth without interference of the tissue above and below the level. That is, a pre-selected plane can be evaluated very well. Panoramic radiography is a technique for producing image. A single radiographic image of facial structures include both maxillary and mandibular dental arches and their supporting structures. External source of radiation. Rotational panoramic radiography method. In this case, X-rative patient, the film can be made moving relative to each other during the exposure. This is called phantomography. So these are the different scientists who contributed in dental imaging. That is, the first one is Numata, who was the first introduced the dental imaging, and Heckman, who who created a standing type model, first with an external imaging, and this is the Patiro, who is he is having the much role in panoramic radiography. So these are the in 1933, Dr. H. Dimeta was the first person to propose this one. 1939, Heckman described the slit technique for the curved surfaces. And 1947, Rijo Veli Patro used the curved film inserted lingual to the tooth in each jaw. So the Patro called this technique a parabolography. Patro observed the panoramic radiograph should be taken placing film extraorally. And 1950, Dr. Robertson developed narrow beam panoramic radiography. And Robertson designed the automatic panoramic 1950. 1959, the first OPG suitable for radiograph appeared. And 1961, commercially available OPG machine came. So the clinical indications substitute a full mouth IOPA radiograph and evaluation of tooth development in children and assessment of patient before and during orthodontic therapy to establish size and site of lesions such as cyst, tumors, etc. prior to any surgical procedure such as innervation of the cyst, etc. for detection of fractures. So tomographic principles, a specialized technique for producing radiograph showing only a section of the slice of patient. Each tomogram shows a tissue within that the section sharply defined and focused. Section is referred as the focal plane or focal top. So by taking multiple slices, three-dimensional information about the whole patient can be obtained. And production of each conventional radiographic slice requires controlled accurate movement of both X-ray tube head and the film during exposure. And 3D zone in which layer structures lying within the layer are reasonably well defined equation. Objects outside the film layer is blurred and magnified to reduce in size. So the shape of the image layer varies with the brand of the equipment used. The general shape of the image layer is used panoramic called horseshoe shape. Now the latest one is called the CBCT. So the history of CBCT was first adapted potential clinical use in 1982 in Mayo Clinic Biodynamics Laboratory. And the initial interest focused primarily on the application of angiography. Y. Array et al. In 1999 created CBCT for dental use. So this is the first type of CBCT machines. So let us see what are the differences between conventional CT and CBCT. So let's take a conventional CT. Here the fan-shaped beam is used in conventional CT. The path of the movement is complex scanning movements. Each slice requires a separate scan and separated 2D reconstruction, and the primary reconstruction of data produces axial slices from which the secondary reconstruction generated orthogonal images. Whereas in cone beam CT, the cone shape of X-ray beam is used in a circular trajectory, and entire FOV can be scanned in a single rotation, and multiple basis projection from which the projection data from which the orthogonal planar images or secondary reconstruction. So this is the cone beam structure, CT, schematic representation. Here the fan beam used for the conventional CT. So this is the conventional technique, and here that's a cone beam CT. So the cone beam image geometry, a 3D cone or pyramidal, if the collimator is rectangular, diverge X-ray beam directed through a patient onto a detector. That is, the X-ray tube is directed in a circular path, whereas it is directed to the detector and is directed to the opposite direction. It is directed the same circular trajectory. So by virtue of this movement, they are producing basis images. So with the basis images, this reconstruction of orthogonal planes are made or reconstructed. X-ray source and the detector rotates. Basis frame or images are formed. Calculation of the image volume or projection data formation, and software program primary reconstruction of the image. So the classification according to the field of FUV. The large FUV scans for the entire craniofacial skeleton, medium FOV, image, maxilla and mandible or both, and focused or restricted scans high resolution images of the limited region, and stitch scans from multiple focused FOV scans, larger area image from superimposition of multiple scans. So these are the different types. Large FOV, you can see the whole of the craniofacial structures, and medium FOV, you can see the maxillary and mandibular, and focused or restricted FOV with a region of interest. Suppose we are to give the molar or canine, like that. So stitched FOV, this can be used for the particular region, either it is mandibular or maxillary. So CBCT systems can be categorized according to the available FOV or selector scan volume. The height as follows: localized region of 5 centimeter approximately or less. This is for bendoalveolar or temporomandibular joints. Singulars 5 centimeter to 7 centimeter for maxilla or mandible. Interarch 7 centimeter to 10 centimeter mandible and superiorly included inferior congruent. And maxillofacial 10 centimeter to 15 centimeter, that is mandible extending to nasio, and craniofacial greater than 15 centimeter from its lower border of the mandible to the vertex of the head. So the components of image production, as any radiographic image system, CBCT requires X-ray production, X-ray attenuation of the object, single detection, image processing and display. These parameters will be more sophisticated for CBCT, and components of CBCT includes X-ray generator, image detection system, and image reconstruction. So these are the different types of CBCT. It can be sitting position and case may be and standing and supine view. Here the head is immobilized and chin cup and bite box forks for other head restrainers. So the scan factors, number of images contributing, the projection data is determined by detector frame rates, completeness of the trajectory, and rotation of the source and detector. High frame rate advantages are increased signal to noise ratio, image with less noise, and reduction of metallic artifacts. And the disadvantages, long scan time, high patient dose, and increased primary reconstruction of the time, or more data is required. And scan arcs, advantages, limited scan arc, advantages of decreased scan time, decreased patient dose, easy to perform. Disadvantage, greater noise artifacts, scan time. Reduction as short as possible to decrease the patient motion artifacts to increase resolution. Decrease scanning time by increasing the frame rate, decreasing number of projection, decreasing scan arc. So these are best for the increased image noise. Image detector used are two types: image intensifier tubes or image charge coupled devices, or flat panel detectors. IIT or CCD configuration consists of scintillation screens, image intensifiers, and charge coupled devices detectors. And FPDs are used. The flat panel imaging system consists of detector X-rays with an indirect detector that is based on the large area of solid state sensor panel coupled with X-ray scintillation layer, composed of large area pixel array of hydrogenated amorphous silicon thin film transistors. And X-rays are detected directly by means of scintillators such as terbium activated gadolinium oxysulfide or thallium doped cesium iodide, which converts X-ray into visible light that is subsequently registered into photodiode array. The most common flat panel configuration consists of cesium iodide scintillator applied to the thin film transistor made of amorphous silicon. Recently, large complementary metal oxide semiconductors technology. So the advantages of image intensifier or CCD and comparing that with FPDs. Large and bulky for IA and expensive, circular image areas or spherical volume. Rotation of the source to detector arrangements may influence sensitivity because of interface between the magnetic field of the Earth and those in the imaginary sphere. FOVs may be suffer peripheral truncation artifacts. And FPDs, high resolution, less expensive and commonly used, and rectangular image areas with cylindrical volume. And configuration of such detectors is less complicated and offers greater dynamic range and reduced peripheral distortion, and requires slightly greater radiation exposures. And reconstruction in case the processing of the data occurs after obtaining basis projection frames to create a volumetric data to set a called primary reconstruction, and the process of creating volumetric data set which composed of cuboidal volume voxels by sequence of software algorithm called reconstruction, and requires two computers, one for the acquisition computer, and in the acquisition computer, data can be transferred to the processing computer that is called workstation. So these are the CBCT image, and so with a basis image, we could be able to get a coronal reconstruction, sagittal, and axial reconstruction. So these are the multiplanar reconstructions done. So in case of mandible, and single projection also can be done to get the alveolar bone thickness, etc. So this is the maximum intensity projection also done, and according to the different types of algorithm or the software used. And these are the orthogonal projection from axial, sagittal or coronal, and with a different volume maximum intensity projection and volume reconstructions, data volume reconstruction, etc. So here the dose in different dental imaging, digital bar of speed rectangular collimator in digital is 34.9, and digital with a round collimator is 170.7. Conventional single IOPH is less than 8.3. Panoramic it is 2.7 to 24.3, and lateral cephalometry it is 2.3 to 5.6. And CT maxilla plus mandible is 180 to 2100. CT maxilla is 1400. CBCT large FOV is 130 to 260. CBCT medium is 84 to 166. And CBCT small FOV is 92 to 122. So that is the different radiation dose, and that is the end of my presentation. And thank you.